Hey everybody, welcome back to the ECG of the day. My name is Reid, and don't forget that you can download today's ECG PDF down linked in the description below, and so you can follow along. And yeah, let's jump into it. So the first thing I'm gonna do is look at the forest, and so I kind of pick a lead, maybe here lead 2. I see I've got this wide complex rhythm. Seems to be very regular, and it's just kind of going through same type of fashion the entire time. If I find a QRS here, they all seem to land right before a solid line, so we'll pick this one and we'll go 300, 150, 100, 75, 60. So we've got a 60 beats per minute, and I tell you what, it seems to be 60 beats per minute the whole way. I mean, look, every QRS is landing right in front, like 1 millimeter exactly in front of that solid line. Not a lick of variation. There's no variation. And why do I bring this up? I wonder if this person has a pacemaker, right? Like, why is this beat so perfect? Well, I look in front and I see some like atrial activity in front of my QRS complexes. What's interesting about that atrial activity, though, is if you kind of look over at the lateral leads, what you'll see is that in front of those P waves, I've got this little itty bitty spike. Look at that. Spike. That's a pacing spike. Right? And so when you have a pacing spike that occurs, and then right after the pacing spike, you have what? A P wave. Then what is this? This is an atrial pacemaker, right? Or at least we were being paced in the atria, right? So this is atrial pacing. Okay. I don't see that in front of my QRS complexes, right? I look throughout a bunch of leads in my QRS complexes. I don't see a pacemaker spike in front of my QRS, so I know that there's pacing in the atria. Okay. So let's try to figure out, first of all, that would explain why my rhythm is so fixed at 60 beats per minute, because the pacemaker is just tacking away, programmed at 60 beats per minute during this ECG. So that makes sense. We said that this is atrial pacing, right? So we know that most pacemakers, if this is my pacemaker box that's sitting in someone's chest, there's two leads, two wires that come out, one of them that goes all the way down into the ventricles, so that if we need to beat in the ventricles, we can. And the other one goes all the way to the atria, so that we need to beat in the atria. And so we know that this person is beating in that atrial lead, and it's depolarizing the atria, right? So we know that that's happening because we see pacing spike in P waves. Well, now let's evaluate the rest of this rhythm. Now we know that the AV node needs to capture that signal and send it down, and it delays that signal. And so let's look at the PR interval and determine how my AV node is functioning. Well, if I look here, you can go from the beginning of that P wave to the beginning of my QRS. And you can see it's a little bit long. That PR interval is like 6 small boxes, which is like 240 milliseconds, which is a little bit too long. So we've got a little bit of an AV block here. We have some AV block. And what's the AV block? Where the PR interval stays the same and every P wave conducts to a QRS. Right, we can see that it stays the same the whole time. There's no P waves that are extra in this. So that was a first degree AV block. So we've got a first degree AV block, right? And you know, you can have a first degree AV block with an atrial pacemaker, because the atrial pacemaker has nothing to do with the function of the AV node, right? It's just depolarizing the atria. So we see a pacing spike, depolarize the atria. The AV node captures that signal. It takes it 240 milliseconds, so a little slow, and it passes it down to the ventricles. And we said we had a wide complex rhythm, right? We said it's wide, and if we look, the duration of my QRS complex is wide. The QRS is definitely greater than 120 milliseconds, which is 3 little boxes, so that's wide. So we have some type of bundle branch block, aberrancy likely, because we know that the AV node is probably passing this atrial signal down into the ventricles, especially because there's no pacing spike. And so the first thing I notice is that my QRS complex has got this R prime in the lateral leads, R prime. We've got this R prime in the lateral leads, right? And so what does that make me think of? That makes me think of a left bundle branch block. That would explain that wide complex QRS. And you can see that I've got these deep slurry S waves in my anterior, kind of the septal leads, V1, V2, those deep slurred S waves in those leads kind of also tell me that there's late signal, because it's slurry, late signal heading away from V1, right, which is towards the lateral aspect that is supplied by that left bundle. And you can see we've almost lost that septal R wave completely, right? Sometimes you get complete loss of it, sometimes you don't in a left bundle branch block. So we've got a left bundle branch block. And then now, the next thing we need to do is just evaluate our QT interval. And you can see that my T waves seem to terminate by the midway point from my R to R's, which is reassuring, so it's normal T wave duration. I look for pathological Q waves, which I don't see any. I look for ST and T wave changes throughout. And remember, we need to evaluate using different criteria. Scarbosa criteria is what you use in the setting of a left bundle branch block to look for ischemic changes, because there's going to be some like ST and T wave strain. I don't see any that falls outside of the normal limit, so that's good. And so what do we have? We've got a rhythm that has atrial pacing with a first degree AV block and a left bundle branch block. And so we know that nowadays the standard of care is a dual chamber pacemaker. And so in this case, what's happening? We have the pacemaker, like we said, is beating in for the atria, and it's depolarizing the atria. What happens is the AV node captures that signal and it sends it down. And whenever it sends it down, we get depolarization through the ventricles. And that ventricular lead in the pacemaker is sensing, and it's waiting for that beat. And once that beat makes its way down, that pacing lead inhibits itself. It doesn't beat because it knows it doesn't need to beat, right? And so what is the kind of the pacing type of situation that we have here? We have something called atrial paced ventricular sensed, right? And that's meaning that what's happening is that every 60 beats per minute, the rate, that initial lead, that right atrial lead, is waiting. It's waiting for the sinus node. It's waiting for the sinus node to beat. And if the sinus node does beat, it would inhibit that lead, but it doesn't, right? This person's sinus node is not doing great. And so that atrial lead is pacing for the sinus node. And then we're saying that because the AV node is functioning well enough right now, that ventricular pacing wire doesn't need to do its job. And so actually, well, it is doing its job by sensing, but it doesn't need to pace. So I hope that helps. And if you have any questions about this rhythm, throw it down in the comments. If you have questions about pacing, modes, types, all the things, comment. It's complex. Pacemaker troubleshooting is difficult. In this case, the pacemaker seems to be working just right. So hope this helps, and have a great rest of your day. Take care.